Welcome to Creative Caregiving and Beyond. More and more people are having to become caregivers for their elderly loved ones, and navigating this journey can be really difficult. This podcast will provide guidance and give practical tips for your family. Your host is Wendy Whiteman, elder law attorney, author, speaker, and leading insight advisor in senior protocol and senior lifestyle trends. Know that you are not alone in getting the help that you need. Let's get started. And here's Wendy.
Well, welcome to another episode of Creative Caregiving and Beyond, where we discuss all things elder related and an effort to help our senior families and our communities and our loved ones. And today we have a special guest. We have Latoya Davis. Welcome, Latoya.
Thank you, Wendy.
Latoya is Marketing Director for Green Oaks Nursing and Rehabilitation Center in Arlington, Texas.
Yes, ma'am.
So tell us a little bit about yourself and how you got started in the elder care space.
Yes, so I have always been around the long-term care community. My mother worked for skilled nursing care as a PT tech at one point. Then she transitioned to be in the business office manager. And so occasionally I would go to the job and sit with her. I've always had an affinity towards the elderly community. I think that they are precious, like precious. So I've always been familiar with the setting. And then when I was in college, I went to work in my mother's building part-time in the business office. And really from there, I never left. I started out in the business office, went into the social services department, then transitioned to the admissions department and now marketing. So that has been my adult job life, long-term care. So very near and dear to me.
Well, that's wonderful.
Yes.
I mean, you've had, you grew up in the area of being exposed to it with your mom, and then you had an internship in college as well.
Basically.
Wow. Wow. Well, you were destined.
I think so.
You were destined to become a part of it. Well, tell us a little bit about Green Oaks Nursing and Rehab. Paint us a picture of what it's like.
So Green Oaks, this is actually my second skilled nursing facility. So I've been there a little shy of 2 years, but been with the company for 10. So it is owned by HealthMart Group, HMG Services, really good company. Green Oaks, I love the building because when you first enter, first of all, it's bright. It's nice and bright, right? So usually when families come in, they're usually down. You know, they're usually confused and don't know what the next step is. And 9 times out of 10, they don't want to have to place their loved ones. Right. You know, even if it's short term or even long term, most times they don't want to have to make that decision. So I believe that our facility is very inviting. Again, nice and bright. It's very home-like. The staff is very, nice and inviting. So I always encourage the families to come and tour. That's a huge thing. When you go to a facility and you tour, you'll get a vibe. That's true. And that is very true. So when the hospital gives you a list of places to go visit, go visit.
That's a very
go
good
visit
point.
And get a feel for the building.
Yeah,
absolutely.
That's a good point. When you buy a house or you look at an apartment, you're going to tour it.
Absolutely.
You're going to test drive a car, so you've got to do the same thing if you're going to place your loved one.
Absolutely.
That's a very good point.
It makes a difference.
Yeah, definitely. And that's probably what makes Green Oaks unique.
Right.
Yeah.
I would say so.
Yeah.
Again, the setting, it's nice, it's bright, it's inviting. We're very informative. So as far as the staff goes, and myself for sure, it is vital that the families have a plan A, B, C, and D, right? Because initially when you come in, usually something has happened that's unplanned, that, prompted your loved one to be in the hospital. So then it's like, okay, what's next? Let's get rehab, let's get them back home. Or what if that doesn't happen? Or what if it doesn't happen in the length of time that you're thinking? 1 week, 2 weeks, sometimes there's setbacks.
That's true.
Where the patients come in and they have a setback and have to be sent back to the hospital. So to me, it's important that they feel, after they leave the facility and you view the physical plan, I want them to be informed and feel like they know or have a plan, at least a map.
Right.
Because a lot of times they don't get that at the hospital,
That's true. That's true.
The hospital case managers are very busy.
Right.
They have a ton of patients that they're working on. And sometimes the information is just not there, or they don't have the time to sit and really talk with that family and give them what they need.
Right.
So that's one thing, that's one area that we shine,
Okay.
I would say for sure.
Well, I'm sure that makes the families feel more comfortable too, if they know they have a plan A, B, and C as to what could possibly happen.
Right.
Yeah, yeah.
Right.
Because it is a very, not necessarily aggravating, but scary time sometimes for families.
Yes.
It's the unknown.
It's the unknown, and everything is unknown. and there's so much to know.
So much to know.
So much to know. Yes.
Yes. So for a family that's just coming in and they're admitting to your facility, do you guys sit down and map out like a care plan or something like that?
So, first we of course will give the tour.
Okay.
And during the tour we're going to ask, are we looking for long-term or short-term? So Green Oaks of course offers both. Long-term would mean, several months to, indefinite. You're living there as a patient.
Okay.
So we do have those space and that availability, but we also service those patients coming in for short-term.
Okay.
Short-term, there is no time frame, right?
Right.
But it is in your thoughts, you're looking for the patient to come and receive therapy services and nursing care and rehab to get back home.
To get back home, okay.
Or get back to your prior level of function.
Okay.
And then, so you're here for a short period of time, however long that is, however long the insurance covers, and then you're discharging.
Okay.
So we find that out up front, and sometimes it's in the middle. Sometimes they don't know, right?
That's true. That's true.
And sometimes they're in denial.
Yeah.
So it takes love, it takes care, it takes diligence to kind of say, hey, this is probably what we want. But what if,
Right.
and let's go ahead and map that out. And sometimes you have to hold back a little bit if the family members are overwhelmed,
Right.
and kind of doctor, and nurse them through the situation. So it's every family is different.
Yeah.
Every family is different, but again, it's important to find out what the plan is, long-term, short-term. From there, yes, we map out a plan.
Okay.
If they are Medicare or managed care, we definitely like to go over that because that's the payer, and that's going to determine how long they're there.
Okay.
Very vital, very important to know for families. Sometimes they think, oh, they're going to get rehab for 6 months. Not quite. And you would believe, a lot of times the families say all the time, well, the doctor said that he needs 3 months of care. He needs 3 months of therapy. And then I have to be the one to break it to them and say, okay, well, your insurance
says another thing.
Right. And it is a week-to-week assessment, so depending upon how well your loved one is progressing, depending upon, because the insurance is not saying we're going to get you rehab to completion before going home, right?
That's so true.
If you can get to a level to where you can stand and pivot to a bedside commode, even if you're in a wheelchair and you're pushing the wheelchair or walker, they're saying you can go home with home health, right? So we have to be realistic and upfront tell the families this so that they're not expecting something that they're not going to get. And again, you have to say that in love.
You do.
You have to say it in love.
And you're talking to me because I was there with my mom like that, and I was like, well, she's not back to baseline. He's like, they're like, we're not trying to get her back to baseline. We're trying to get her to the point where she can leave and go home
and continue therapy at home.
Well, what am I to do then? So how involved do you get the families, and how involved should they be in that process when they're rehabbing? Are they welcome to come in and encourage during that process, or?
Yes, they are welcome. Now, if it's going to be a hindrance, then we'll kindly say, hey, because a lot of times our patients do everything for us. Well, let's get up, let's get you dressed, let's get you to the therapy gym, let's get you to an activity, and we just go with it. And then sometimes when the family comes in, it's they become a little helpless, and so if we notice that, our therapists are really good. Again, shout out to our therapy team. They're really good with seeing that, and so they'll kindly tell the family, hey, during therapy sessions, we prefer to work, one-on-one with the patient. We're getting more out of the patient, that way. Right. And then you have some patients who require more, who may need one-on-one. And we don't have one-on-one in settings like that. Okay. And so we are very good with allowing the families to come in, stay the night if need be. Oh, okay. We have a lot of that happen because it helps us as well. Yeah, the families are there. Yeah. They're comfortable because they see what's going on and they can still do for mother or father. But we're in addition to that with our therapy. And so we welcome that as well. It just depends on what the patient needs.
Very good, very good. Because I'm sure that helps the patient too, that especially the patient that doesn't want to be there.
Absolutely.
I mean, that's probably, you don't really come across a lot of people that want to be there, but it's necessary.
Right.
Yeah.
Right.
And then just getting them to segue into the environment.
Right.
Yeah.
Right.
Wow. That's great that you guys are very thoughtful. Now, we were talking earlier about Medicare and how when you're a family member is discharged from the hospital, they come in on skilled nursing days, and Medicare could cover or managed care. Can you elaborate on that whole protocol? Because I know that can be very confusing for families. And I don't handle the Medicare part of it either, so I'm learning too. So I'm going to take some notes. So you go ahead.
Absolutely. So when you go into the hospital, and of course, you know, if the physician is requesting that you go to another level of care to continue with therapy. First thing families say, well, they're not doing therapy in the hospital. He's just laying there, nothing's being done. The hospital is there really to fix the acute issue, right? They have therapists on staff to get those initial evaluations done. When you're coming to a skilled nursing setting and you're submitting the information to the insurance to review, that's what they're looking at. I need to see the therapy evaluation to see what the patient is doing now, what their prior level of function was. That's the main thing that they're doing in the hospital. Let me get an eval in, let me move to the next patient. They're not there to kind of rehab you back to you know. So when you come to our level of care, that's when the rehab starts. Usually we do about 5 to 6 days a week of therapy. We offer physical, occupational, and speech therapy services. And so when we initially get the referral from the hospital, let's say you have traditional Medicare. A lot of families sometimes get confused because they'll see like on the card, United Healthcare, Medicare Advantage. And when they come and tour and I ask, you know, what's your loved one's insurance? They say, oh, they're Medicare. Well, I've learned now sometimes I get the card, it's United Healthcare, right? Which is altogether different. Traditional Medicare for skilled nursing settings gives you a total of 100 days. So you have 100 days in your benefit period. The first 20 days are covered at 100%. So that means if you come in and you're there for 20 days and you know you're still rehabable, those 20 days are covered in full by Medicare. If you're there for days 21 through 100, the Medicare copay starts. And that's $204 a day. So with that, if you don't have a secondary insurance or a supplemental, then of course that copay is pretty high.
It is.
So you know you're left with, okay, let me try to get as much done in those 20 days as I possibly can. And then what do I do from there? Right? Again, with Medicare, there is no following case manager. So as long as the patient is making notable progress, then we can continue to skill that patient. And the facility is the one that determines how long the patient stays on. We have to, of course, monitor that. We can't skill you just because you have days. But you're not, you know, you're no longer making progress. So, but the facility is the one that can handle that with in-house. When we're working with the patient one-on-one and we can see real time what's going on with the patient. So then you move to your managed care plans. So you have your managed care plans, which can be just commercial plan, or you have your Medicare Advantage plans. So that's where the managed care company and the Medicare are kind of married, they're cousins. So the managed is managing the plan, but they're following Medicare guidelines. So for example, you have like United Healthcare Medicare replacement policy or Medicare Advantage policy. Same breakdown, the first 20 days are covered at 100%. They may have days 21 through 45 where you have a copay. Then you have a deductible that has to be met and your maximum out of pocket, right? So if you meet your maximum out of pocket, there is no copay days once you get to day 21. So there's some pluses. That amount can vary, right? The other huge thing with that is it is a week-to-week progression. So before you come to us from the hospital, we have to submit that referral, those clinicals, to the managed care plan. They review it. They determine whether or not we feel like the patient's even skilled appropriate to leave the hospital. So we have some patients where they have had decline, they go into the hospital. There was definitely an acute reason for them to be there, but that managed care plan may feel like they don't need inpatient skilled nursing services. They can go home with home health and do 3 days a week of therapy, and that's all that they need. And sometimes in real time, that's just not what it is, right? Part of my job is to go to the hospital and do the bedsides. Okay. So I go in and I see the patient, I talk with the patient. So and I'm able to speak with the nurses and find out, ask any questions if need be, and talk with the family. So I'm looking and I'm seeing, I'm hearing from the family what's happened, and they're distraught. Like, what do I do? And yet you may deal with case management with the insurance companies that may say, we don't feel like the patient needs it based upon what's on paper.
Right, and they've not actually had contact with the actual patient.
Right, because we're just submitting the referral, right? So a lot of times we've had patients, who they'll offer what they call a peer-to-peer, and that's a physician-to-physician conversation, where maybe the paperwork doesn't reflect it, but that physician is saying, hey, this patient needs it. They have that conversation, and then they can approve it at that point. Once you get to the skilled nursing setting, it's a week-to-week assessment with the managed care companies, which means every week we're submitting updated therapy notes and nurses notes to that managed care company. They review it, and based upon that information, they'll tell us, hey, we'll give the patient another week. They give us a 2-day notice as to when they're going to pull out.
Wow.
So it's again vital that, when the patient admits, we have that conversation with the family. We have what we call a care plan meeting, where we have the social worker involved who handles all the discharge planning. We have someone present from therapy in our nursing department, and they kind of go over the plan of care. So we should already know, okay, hey, patient will definitely be safe enough to go back home. There's family involvement. Do you have a home health company that you used before? If not, we can refer you to one. Do you have a walker at home? Do you have a wheelchair? If they have those things, that's one less thing we have to get for them. Right. But we have to get all that in day one.
So you're getting ahead of the game.
We have to get ahead of the game. We have to. Within 48 hours, we have that meeting so that we can have all that information, because when you're dealing with managed care, like I said, you don't know. It could be week 2, and then all of a sudden, Wednesday, we've got a letter. They're going to stop covering in 2 days.
Wow.
So it's important to have that information and have already talked with the family so that they're not thrown off. Right. This is what managed care is.
And that's where we get the call.
Exactly.
And our families are just so nerve-wracked.
Right.
Because like, what are we going to do? What are we going to do?
Right.
Yeah.
Right.
Yeah. So how would a family, you mentioned peer-to-peer.
Yes.
How would a family know to even request that? Or is that something that
is something the insurance does.
Oh, the insurance.
Right. So what happens is we submit the initial authorization for the patient to come to our SNF setting. And they can say, we're gonna deny it. We're sending it to our medical director based upon the information that we have. We don't feel that the patient needs that level of care. So then they will offer, at that point, a peer-to-peer. The insurance will. And so that's when we pass that information usually to the hospital case manager. They get in contact with their physician immediately, because usually it's like a couple of hours time. You have until 2 p.m. to schedule a peer-to-peer. So they don't make it convenient. It's like, get to it, and then at that point, after that peer-to-peer is had, sometimes they'll approve for the patient to come, and sometimes they will still, hold their ground and say, no, we don't feel like the patient, is skilled appropriate.
Wow.
Yeah, and the patient's at the hospital either has to go home. A lot of times they'll end up right back in the hospital because they were not ready to go home, or they may have to start the Medicaid route, if it's a case where they're not going to be, able to go home within a certain length of time.
And also be able to afford the copay part of it.
Absolutely. You're right.
Because that's pretty substantial for a lot of people.
It is. It is.
And
very much so.
And when we were dealing with families, we handle that other financial part of it when they're applying for Medicaid, but you guys see the medical necessity criteria, and we'll tell sometimes we'll tell our clients, well, that's another component.
It is.
That, we have no control over, but the facility's going to handle that. Can you kind of elaborate on those protocols and how that works?
So now we're talking about Medicaid.
Medicaid, yes.
Medicaid.
Thank
so
you.
Medicaid is what we will call a long-term payer, right? So if you're coming in for skilled services, for therapy, usually your medical insurance is going to cover that. So your Medicare, your United Healthcare, whatever your managed care plan is. Once that stops and you're like, you know what, mom is doing well here. We like the setting. She's thriving. We want her to stay long term, right? So then your payer goes to either private pay, if you can't afford that, Medicaid. Medicaid has both, you have to meet both medical necessity and financial, which you guys are real versed on the financial.
Yes.
The medical necessity piece is, it's a bit complex, right? Because, as a family member, if we're thinking, well, mom can't walk and mom can't prepare her own meals, you're thinking she's appropriate for a skilled nursing facility to live there. And Medicaid's like, no, right? They mainly look at what your cognitive deficits are. So things that will get you medical necessity, if you have, dementia, if you have Alzheimer's, if you're legally blind, let's say you're diabetic and you're legally blind, you have to take insulin. You can't see to take that, you'll get medical necessity. Things of that nature. Now, if you, are not ambulatory or not able to walk around, but yet I know if my phone is here, my medications are here, I know what medications to take. If something's wrong with me, I know I can pick up the phone and say, hey, something's wrong, I'm calling 911. You're likely going to have to be at home, even if you're not able, you're not mobile, So there are some things, of course, that I'm like, well, surely we can get medical necessity on this patient, and sometimes it doesn't fly that way. So a nurse, a licensed nurse is the one that will make that determination. We have our regional team, along with our MDS nurses, our billing nurses that can look at that because they know what diagnosis Medicaid looks at and how we can get that approved. So that's a whole process. On top of financial.
On top of financial. But primarily the cognitive issues would be the trigger points. What if someone has not necessarily been diagnosed with a formal diagnosis of Alzheimer's or dementia, but they're exhibiting those qualities? I mean, does the nurse take that into consideration?
Absolutely. Absolutely. Now, the thing is, if you're coming in under your managed care or your Medicare plan, right? So we know that you're coming in initially needing therapy services, so you have a payer coming in, and we know that they could roll over into long term. Even if there is not a diagnosis already verified, we can look at that patient once they get to us. Because if there is cognitive deficits or there's confusion and forgetfulness, we can look at that. We have a company that will have come in and assess the patients for that, that can give that diagnosis. So we'll be able to look into it a little further. And really dig through the clinical and see the patient, and it gives us a clearer picture to say, hey, we can definitely get medical necessity based upon these things. So it's not always black and white. We can look into it for sure. And I imagine that happens pretty fast as well. It does. It has to, because then we have to know what's happening, what's going on, so that we have to always be ahead. Because you really don't know. Some patients progress pretty quickly, and the ones that you're thinking are not going to recover quickly and not going to be able to go back home do, and then you have some of those who come in and they don't.
That's true.
So it is really a day-to-day
basis.
Absolutely. And every patient is different, so you kind of have to join the ride and see what happens. Communicate.
Well, Latoya, it seems like you're prepared for anything, any stage that comes along, and you've got the experience to back it up too.
Yes, absolutely.
So what if there's one thing you could change, or a couple of things you could change in the elder care space? What would that be? What would that look like for you in a perfect world? What would you do?
Well, there's a lot of things, right? But to shorten the list, I would say, I feel like the ones that do, when you come into a skilled nursing setting, let me explain that. This is a question really that families have, or that they don't know, right? In the hospital, the nurse to patient ratio usually can be 1 to 6 patients, maybe 1 to 7 or smaller, right? When you come to a skilled nursing setting, that is not the case. You have anywhere from 10 to 14 rooms on each hall, and then sometimes you offer private rooms. We do offer private rooms upon availability, but then you also have semi-private rooms. There are 2 patients to a room. So one nurse can have 20 some odd patients.
Wow.
Or 20 patients, 15 to 20, right? Now we do, you'll have your nurse, you'll have your certified medication aide who passes your medications, and then we staff our CNAs. Okay. Our certified nursing aides, near and dear to my heart, right? Because they do a lot of work.
They do.
Example, if a patient comes in and they are total assist, which means they need assistance with everything. That means bathing, getting dressed, possibly even having to be fed. Whatever that patient needs, that aide is having to tend to that patient for that. That patient and several patients. So it is important that you staff your aides accordingly to make sure that they can handle the load of care. But the work in general, to me, I don't feel like they get paid enough. I think the certified nursing aides do not get paid near their worth. Especially the good ones. Absolutely. Absolutely. So that's one thing I would definitely change. Now our nurses, yes, they have a lot on their plate as well. All the other areas, but those aides, again, I think just monetarily it doesn't match the work that they do.
And they're the first line of defense. I mean, they're the ones that are hands-on with the patient as well as the family members.
Yes. And
they're probably taking on the complaints as well.
Of course. Right? Because the patients come from various places. Right? So mother may like her coffee at 7:30 in the morning. Hot. A little touch of milk.
Right. Touch of milk.
Well, every patient has their own thing that makes them enjoy their time there better, that makes them easier to work with. When therapy comes in, if my aide has come in and got me dressed, my face is washed, I'm feeling great, I've had my coffee, therapy comes in, I'm ready to go, right? And so those aides set the tone. After a couple of days, those aides already know, hey, I know, Miss So-and-so loves so-and-so, let me get her up. She doesn't like this, she doesn't like that. Mr. Jenkins, he loves this and this and that. So you have to kind of all together make it work and make their stay as pleasant as possible so that we can do other things and they'll be more willing to do other things.
That's true.
And the families really rely on those aides, So to me, that I would change that for sure. They would need a pay increase, and that's across the board.
Across the board.
That's across the board.
Yeah, I've heard about that, and I'm sure they would be excited to hear you advocating for them in this podcast.
I would hope so. It's a real thing.
It's
a real thing.
Well, that's great, and we'll keep that in mind too. When next time you see a CNA in a nursing facility, make sure you tell them how much you appreciate them and
absolutely,
and how vital they are in the whole process with our families for sure. Okay. Well, Latoya, thank you so much for coming on the podcast. This has been so informative.
Thank you, Wendy.
This has been wonderful. And if a family member or audience wants to tour Green Oaks in Arlington, how would they get in contact with you to see your facility and see what great things you guys are doing?
Thank you. Absolutely. So you could call 817-222-6000. That's the main number. We are located in the southeast Arlington area, so we're kind of close to Fort Worth, also in Arlington. You could also contact me at 832-948-5467. I'd be happy to help you or assist you with anything. And if you have questions, you're just not sure what route to go, and you don't have clarity, on the managed care plans, whatever it is, feel free to reach out to me. I'd be happy to help. It's a passion of mine, so.
I can tell.
It is. I could talk all day about it.
I can tell. Well, you were born for it.
Thank you.
Born for it. Thank you for all you do.
Thank you
for all you do. Well, thank you, audience, for tuning in. I hope this has been informative for you, and we look forward to many more episodes with more information in our elder care sector and how we can make it a better world for our seniors. And don't forget to like and to subscribe to our channel. See you next time.